everyone, and welcome. My name is Dr. Beth Brooks, and I'm the clinical advisor here at Vivian Health. And today we're going to continue with our series on the horizon in healthcare. And as you know, we've been doing a variety of web interviews to help talk to experts about some of the topics we've been covering. And so recently I did a session on the relationship between the CNO, Chief Nursing Officer, and the CFO, and talked about some of the newer approaches to that very important relationship. And so today I've invited Amy Trueblood to join us. And Amy is the Chief Nursing Officer for OU Medical Center, Oklahoma University Medical Center, which is part of Oklahoma University Health in Oklahoma City. And Amy is a nationally board certified nurse executive from the American Nurses Credentialing Center. And I have known Amy for a very long time and have been able to see her throughout her career and have seen her learn and grow and develop as a leader. And so she's also working on her PhD in nursing at the University of Missouri, while she's also full-time the chief nurse, so she's quite busy. Amy's the fortunate chief nurse in that she's had both experiences as a director of nursing, but both at the facility level or the hospital level, but then she's also had positions in the corporate office or at the system level. And so his experience with, building a system float pool, understanding patient engagement, understanding patient experience. So she has a really rounded level of expertise and experience that she can bring to the table for us today. So again, we're going to talk a little bit about how important that CNO and CFO relationship is to nurse staffing, which we all know is really important to any nurse that you're considering to recruit to your organization. It will inevitably be a question during the interview process. And so having a good understanding of how nurse staffing is determined and workload, do tell that story to that applicant and make your organization an appealing employer to them. So we want to talk, Amy, start with, we both know about the report that came out a couple of years ago, the collaboration between the Healthcare Financial Management Association, the American Organization of Nurse Executives, now the Nurse Leaders is the new name of the organization, and the American Nurses Association. And they have identified, as we all know, it's a really important relationship between the CFO and the CNO. And because nurse staffing is A, the largest part of the labor budget, and B, we know that nurse staffing is really important to quality care. So I wanted to just have you start by talking about this. What the report brings forward, I think, really well is different language. Nurses talk with one set of terms, and finance team has the same terms, but they define them differently. And so sometimes we're trying to collaborate. We want to collaborate, but we need to maybe clarify those terms because we're all thinking of things differently. So I wanted you to talk a little bit about, how do you have those conversations, and what does ratio mean to us versus nurses versus the finance team, and just talk about how you've worked through some of that with your team there.
Yeah, absolutely. I think the translation of different languages is one of the key competencies of a nurse leader in all settings. We've got to know how to speak to the CFO, of course, in this example, and we'll talk more about that. We've got to know how to translate messages from an executive corporate level to a staff level in a way that's inspiring. And so the art of translation is huge, but it requires that, I believe, chief nursing officers, nursing leaders need to understand the financial language in a way that maybe we haven't always done before. So we need to do our homework and learn that, and then figure out how it is that we can translate to the language of the CFO in a way that meets in the middle. And it isn't adversarial at all, but rather not saying you just don't understand me or I just don't understand you, but being the leader and making that understanding kind of come together so that people can understand when you, and so I know that, and in order to know that, you need to spend time talking with and immerse yourselves in the CFO office, in the language of peers. I do spend some time in those those journals as well to kind of make sure that I'm up to date also and can to explain and understand in the terms that are out there nationally what it is that we're really facing in our one organization, and be as specific as we can in what it is that we're requesting and what the impact, while 120% productivity is green on their report, or I'm sorry, that's red, and or green looks good, understaffed, but from a financial perspective, but explaining what that means is happening to the workload of the nurses and the care that's being provided to the patients. So we can actually have done that to where we've made that a neutral color, and can really just discuss about the number and what it really means, the impact on the nurse and the patient, rather than solely the overlook that might happen if somebody is on a what appears to be financially really good productivity.
So talk about that a little more. So you've said, hey, finance team, that might look good to you, but here's the outcome at the bedside. So just a little bit more, talk about that.
Here's what that means. Yeah, I actually had a great CFO when I was in Colorado that really taught me around that particular piece and spearheaded us doing that out there. I was in a director role, but making this a kind of neutral report out to where we would only be green if it was really right at 100% or 99 or 101, but anything on either side was red of that. And he really understood that. And that's a conversation then that we just have and explain. Obviously, that looks good, but here's what it means very simply. And you take it one example and you say, if that was 20% understaffed, that's how they got to that number, and just give specific examples. One thing I really have found to be true of, I believe, all of the CFOs that I've had the pleasure of working with, is that they really are involved in healthcare because they want to make a difference in patient care too. And so helping explain to them how they can then help you make that discussion known in their language and their peers, and also where can we come together to where we're not just asking for resources all the time for no apparent reason or for some sort of kind of soft reason, but that with onus is on us to be able to make a case for what we need in real objective terms and financial terms, but also we can paint that picture of patient care and explain a little bit of we can give a little here, and we need to have a little more here. And I found that to be really, really useful. But yeah, I loved that CFO approach that we had in Colorado, and we're using it here now as well. Let's only talk about it as good if it's spot on.
Yeah. Well, and what's interesting is I was preparing and reading and for this session and the prior one, it never really dawned on me. And I've been in this business a long time, and so have you. When a nurse says ratio, we think patient nurse to patient ratio. That's what immediately comes to my mind, right? If you say ratio in front of a finance person, they think a profitability ratio, an efficiency ratio, a liquidity ratio. They have a completely different view of how they look at those terms. And I think that was the one thing when I was reading, I'm like, it's like the light bulb. No wonder we're talking at cross purposes, because some basic terms we don't necessarily define in the same way. So,
and even when you're talking about the same ratio, let's say we're talking about hours per patient day, that's a simple metric to our finance team where they say that's how many hours were worked per patient day. And the nursing leaders want to know, okay, but how many of those were productive? How many of those were nurse hours? How many of the, and so we might say hours per patient day, and I mean nursing hours per patient day specifically. And the finance team is thinking of the global number for the total worked hours or something like that. And so even there's a need there to always be very clear about what specific hours are you including, because you can look at that so many different ways and come to very different answers. Also, to be clear on the expectations. So I'm sure most of my colleagues across the country are familiar with databases that we can benchmark again, those different things. We were just talking about this week of it's so important to understand and make sure your CFO and your finance team knows to investigate what is the ask of those that are giving the data into those benchmarking systems? Are they asking for nursing hours, direct care hours only? What are people including? So as much as we always look and find out, is it an equivalent organization, department, et cetera? Does it seem like a good match for a benchmark for me? But the really important question before you even select or delve into the database for your CFO team to be talking about is, what have people included in there, so you know that you're comparing apples to apples. If somebody who put information in the database took everybody out except for direct care RNs, and you've got everybody in yours, you're going to look well over the benchmark. So it's really important to know what we're looking at. And I've found that sometimes even our CFO partners and friends weren't aware of that, exactly the need to be that specific.
Yeah, well, and that's a great point. And actually, you did sort of have segued into my next question. So it would be more precise if we said N nurse hours per patient day, right? But then we don't always talk about it that way. We say HPPD, hours per patient day, and that could be everybody. And the finance team doesn't know who to include, really. So that's, like you said, apples to oranges. That is not the best approach to benchmarking. I'll say it that way.
Right. If you're comparing a unit that may use a different compilation of staff or different care model or anything like that, then you've got to know what exactly you're looking at and benchmarking against. And typically they're the first team to look at those benchmarking data, and then they'll share with the rest of the team. So I've always make sure that they know that's something that I will ask immediately when shown that data is, wow, what is it?
So talk a little bit about my next question was about using hours per patient day and average daily census for nurse staffing. And, it's been a tradition forever and ever and ever. And, a lot of it was predicated on billing and how many patients are in the bed at midnight. So talk a little bit about the challenges of using maybe just exclusively average daily census and hours per patient day for nurse staffing, because there are challenges there, right? It doesn't really often help us completely understand the work for the nurse.
Yeah, exactly. That's the problem. I think our friend and colleague, Dr. Therese Fitzpatrick, would call this the flaw of averages. And there are certain things that are not considered, obviously, with a number that's taken at midnight. Most nursing leaders are aware and try to articulate that the flow of patients, the churn of patients, as we might call it, the in and out, isn't reflected when looking at a number at midnight. Surgical units are a great example. Typically, they might fill up and then empty out for a weekend, for example. And so then you've got a Saturday and Sunday, not always, but often lower volume than lower ADC at midnight, or lower census at midnight than the rest of the week. That carries down their entire average. And so here you are on Wednesday and you need to be able to staff for full, and your budget is based off of your average census at midnight. So you can't even come close to what you need on a Wednesday, for example, when you're at a higher volume time. And that's true of trends in any area that trends up and down based on seasonality or anything else. So the issue lies with everything that's happening within that day that isn't reflected based on the number of people that are in bed at midnight. And the other piece is typically then also, if you think about it, let's say we'll try to do something easy. Let's say you have a 20-bed unit with an average daily census of 12, just for ease of calculations, average midnight census of 12. When somebody looks at, okay, we're going to use 12. The other factor that people forget about is typically then the units will be asked to budget, or departments will be asked to hire to 80% of 12. Or somewhere under that. People rarely budget to 100% occupancy. So if your 12 is your occupancy number that they're using out of 20, you only, for your own unit, can hire 80% of that. That's a factor that most of our financial teams don't think about. When we talk about when we have vacancies to the 80% of 12. So if we're at 20, that just multiplies that vacancy even further. And that's something that people will say, oh, we put 20% in the flex pool, and that's an approach, but it's not a precise approach. If you would look at optimally what were your volumes at every hour throughout the day for a long period of time, and then figure out based on your department trends of PTO, FMLA, all of those other things. That's the workforce optimization work that Dr. Fitzpatrick does. Then you overlook all of that, you're going to miss. But if you look at all of those factors, then you can precisely know what percentage you need to budget for in your particular unit based off an average volume of hourly the census every day. So
Yeah,
it's
so
a dream world.
yeah, well, but what's so interesting, as you're talking, I'm like, okay, there's probably the third thing, maybe four, that you've said. Make sure that you're clear with your finance team on how are we defining hours per patient day? Is that just RN or is that all caregivers? And then how are we defining vacancy and census? I mean, you've kind of ticked off these three or four things, the benchmarking, whoever's database it is, what are they reporting versus what so you're making like a nice checklist here of conversations to have with the CFO team to make sure that we're all on the same page, because that was, repeatedly stressed in the report, The Business of Caring, how common language, common understanding for each discipline's perspective, and then having the conversation really facilitates the ability to have that be a more collaborative relationship. What is the relationship between staffing and quality, or staffing and cost effectiveness? Because it seems maybe, or you tell me, how does the finance team define quality? And how does the nursing brain, nursing department define quality? And then how do we interpret or express how important nursing care quality is to the quality overall of the organization? Because I don't know that the finance team and the nursing teams are even looking at quality the same. Maybe they are, but I don't know.
I'm not sure that we are entirely. I do think there's certainly been some improvement in that over the years. And again, I've personally been blessed with CFOs and finance teams that really understand or are willing to listen and learn together about what exactly that can mean, and where the financial and patient care, clinical quality kind of intersect, how one leads to another. I think we've come across a couple of issues over the past several years in terms of making those arguments. I think there's definitely evidence, right? Nursing staffing and ratios and the composition of your staff and a bunch of factors there, not just how many are there, but who's there and what's been their preparation, and all of those other things have an impact on the quality of care that's provided. The thing that we have been struggling with, I believe, is really making a case for that in individual levels, and really demonstrating major successes in these quality outcome areas. I was looking at, this is kind of embarrassing and I need to own it, but I was looking at my goals from 2009 when I was a manager in another organization, and they are the exact same as the goals and categories of goals that are on our list now. Infections, calls, these nursing sensitive indicators that I think we need to figure out what is the key driver there. We know staffing has something to do with it. How do we actually identify that and get to some areas of outcome? Because I was just really struck by that. I know it's a different organization, so I don't know if those are still the manager's goals in that organization, but I have a feeling that they are, that we're all still looking at the same things we've been looking at for years. My point being, we do need to start to demonstrate that, look at this, when this staffing is this way, here's a place that we have really made improvement. So I think when my CFO team here looks at our quality, they understand the human aspect that's there, but primarily they're looking at the financial impact of our quality, whether high or low in certain areas. So we know, and it does help to be able to articulate, listen, this nurse may cost X, but it has the potential to change quality outcomes for the better and here's how we're going to get there, and then follow back up with actual fruition of those goals and actual savings. That's the part that I think we as chief nurses and nursing leaders need to own, is that loop back to say, look how we did this, thank you, we were able to get these staff members, and then all the other work that has to go on, because it's not only staffing, but staffing is a huge part. Get that settled, then get in there and actually get the outcomes and be able to follow up and say, this is where we're really seeing improvement in these care outcomes here. Otherwise, we're just kind of talking about potential that doesn't maybe come to fruition all the time, or we don't loop back and let them know we actually were able to make that return on that investment.
Mhm. So do you feel, and this is probably a very subjective question, would you say for the most part, the finance team understands that, you can't look, I was on the quality committee of a board, right? And if you looked at only the quality dashboard and looked at the metrics, and there was red, I'm making this up, but there was a red metric on whether it was CLABSIs or CAUTIs or hospital acquired pressure injury, whatever the metric was, to look at the metric and whether it's gone up or down in isolation of not understanding what the staffing was like at that time. And that was one of my comments, or always asking at these board meetings. I think this is a great quality report, but how are we getting that quality? What's that staffing look like? So do you think that there's a greater appreciation for how connected those two variables are? Does the finance team understand? Well, first of all, they understand, I'm assuming, how expensive patient safety events are. If there's a
Right.
negative patient safety event, the finance team pretty much knows that that's going to cost money.
Right.
So do they connect that with the staffing and pull those pieces through, or does it, you tell me. I mean, I'm curious what you think.
I think it's probably same as some do, some need some more help. I do think we do have the onus is on the nursing leadership also to just make sure that that's always clear and top of mind as we look and just say, if we're looking at a bad financial month, for instance, that, but we might put that right next to really high quality outcomes or something, bad staffing financially, I mean, from a productivity standpoint. But I think that people with as part of our role to also continue to explain and demonstrate a relationship between all of those things. So typically I have seen over the last several years in a few different organizations where all things are together on one dashboard, so that, and that would be whatever your financial metric is for the nursing departments, as well as then all the quality all at the same time, or seen a kind of put staffing hours behind everything else on a graph, and so you can really keep an eye there. And I think that's a great testament to the work that chief nurses have been trying to do for years to make sure that that happens. So grateful for that, and that people have continued to push that, because it's really important piece to look at there as well. Patient experience, that type of thing. I think we need to do more of that as well. Look at those relationships a little bit more closely, and just see how staffing and or stewardship might impact patient experience as well.
So talk a little bit about, you're relatively new in that role. So you had to come into that organization and create all these relationships, these new relationships, right? So maybe share a couple of strategies or techniques you've used as the new CNO, kind of coming in and establishing a more collaborative relationship with the CFO, especially if you've come into an organization where the approach has been not as collaborative, right? And maybe it was a very conventional approach to finance, where finance is maybe having a little more influence on the nursing staffing budget and whatnot. But then as you come in and you want to build this collaborative relationship, what are some of the things you've done or strategies you've used either now or in the past that have been really helpful to build that collaboration?
Sure. Yeah, absolutely. I think I would call the where I have come to now as more of a traditional approach historically, and also partially because I believe there was kind of a lack of understanding historically from on the nursing leadership end of the need for these relationships and or the ability to kind of make a plan around what is it that we're trying to do and have an organized nursing operational plan. So those are critical pieces that I started doing right away. I meet with my hospital CFO. I have since the beginning once a month now, but since a year ago, it was every other week. We were looking at different strategies, contract labor, obviously things just really big situational things that we were looking at that time. But I believe he was sharing that he hadn't done that often, if at all. With my predecessors. So I think that is a change, and it's important that people know I'm not running from the conversation. Like if there are areas where we need to improve, we will definitely improve. And here's plans and how we might need to do that. And then here's the outcome from why I need to have something more in a certain area. And here's what we would get there. And here's my commitments and follow up on all of those things. So staying engaged in that conversation to say, okay, we do this with contract labor. We're going to be working on hiring and retaining at the same time, and we'll have our contract labor reduced in 3 months, 6 months, whatever it is. And then making sure that we're following up and accountable to that agreement and those plans as well, because that starts to build trust as they see that you will follow through, get outcomes that are needed, and be managing that with the patient care as well. And I think primarily, and then with our system financial leaders and I have built tremendous great relationships, and that comes through a lot of questionings, listening to understand where they are coming from, getting to know people as people. That's a huge thing. Understanding their motivation, which, like I said, I'm just blessed to have a group of people that are as focused on serving the community and our patients as I am. So I think that's been a real blessing. But continued follow up, not shying away from conversations, owning when you've made a mistake or something hasn't gone as planned, and action plans as to how you're going to get back on track. So I think that's just a really big piece of it is building relationships. That's true of any leader in any role, but really important as the chief nurse with the CFO and the financial team.
And then so you're obviously too then, Amy, role modeling those behaviors, right? So, or you're having a conversation with your team about your meeting with the finance team. So talk a little bit about how that the benefit, if you will, of that collaborative relationship kind of trickles down, because I'm assuming the CFO is having the same conversation with his team. I'm collaborating with the chief nurse on these areas. And then, so because I think at this unit level, there can be a lot of blaming on the bad staffing on the finance people. And so how do you sort of build that relationship, that collaborative relationship down in the nursing area also?
Yeah, it was really, really important strategy on my arrival here also to elevate our nursing managers and our directors into these conversations. They're the ones that have the real knowledge of what's going on and a need to understand this aspect of care as important as the other aspects of care that we look at. I mean, I always tell my teams this is about balance. Generally, every place that I've ever been, I believe everybody in healthcare's job is to balance clinical quality, patient experience, employee engagement, and stewardship, finances, however you want to say that, all at the same time. So any tip one way or the other is going to have a negative outcome in at least one of those things. And so our job is to try to balance them all. And that goes to the staff as well. Part of that is don't take 5 sets of sheets into the room. I mean, that might be somebody's balance, finances and quality and patient experience at the same time. And ours obviously things get a little bit more complex as you look at different levels in the organization. But we just recently did a workforce optimization engagement, and we had our managers and in some cases supervisors involved with our finance team in all of those conversations. And I really think that served as a good foundational learning for our frontline leaders as to how do we look at all of these things when you've been used to kind of just being handed a target and then without having much involvement in it. I think that while it might have been a little overwhelming, it was a good instructional and experiential learning for all of them. And then they begin to collaborate together independently and really start to see each other as partners rather than one person allowing or not allowing something to occur.
Yeah, I think that's a really good point, especially. So is it, and how, this is maybe a question that's hard to answer, but how long does that take? If you come into an organization, is it 6 months? It takes a year to build this collaboration? Is it, it depends on, I don't know, the culture of the organization, the tone the CEO sets. I mean, you could keep trying. How long does it take to really feel like, okay, we've got a partnership here? He understands or she understands me and I understand them, and nursing and finance, and we're on the same page now moving forward. Other places, like, is that, does it take forever? Does it take
I don't think it has to take forever. Our other colleague, Dr. Dempsey, says it takes 56 seconds to build a relationship with somebody or to make a personal connection, right? So I think that's strategies that can be used as well. It is really important to build relationships with people, and that, in my mind, in every transition I've ever made, that is the first thing. Trust is the biggest thing, right? That ultimately everybody's looking for, and that can take some time, but you got to get started right away building that. Dr. Covey's trust account, right? Bank account, the emotional bank account. That is really important to start building, start getting those credits in your account right away. Then everything becomes easier. So I think that if we can focus on that and stay focused on getting to know people, getting to understand where they're coming from, even if you don't agree, at least if you know that, then your approach changes, right? If I can find out this person really maybe doesn't value quality that much. This is not a true example, but maybe this person doesn't really, that's not going to work for them. They want to see hard numbers and they want to know a specific action plan of how it's going to do there, and they don't want to hear about patient experience. Maybe they don't want to hear about, then at least you know that, and you can tailor your approach to your requests or your action plans or whatever the situation is based on that, and you know who to go be a bit more direct with and who you can go a little bit more on the quality side, or what is going to help get done what you need to get done. I think that's the biggest job of translation, is knowing how people will respond and what approach will work best to help move where we believe that the organization needs to move.
I couldn't agree with you more. And my last question, or my last, closing, if there was one, recommendation or pearl of wisdom you would give on building that collaborative relationship with the finance team, I think you just said it, right? It's about the relationship. And so is there any other pearl of wisdom around? I have found this to be really an important thing to do, or one last pearl of wisdom you might have.
Gosh, I think that maybe not anything entirely new, but the relationship building is huge. That's the biggest thing again. And I think sometimes I've seen over time, sometimes the defensiveness of sorts from nursing leaders at times, because it feels like, and we have kind of had to struggle and kind of claw our ways to these conversations over time. And so I would encourage people to go into every relationship as a different person. It's a different, every organization is different. You might be the same and bring your same styles there, but might need to look at some different nuances for how you're successful or how you approach things in a new organization or in a new environment, but always starting with getting to know people and having them get to know you. And we can hopefully move forward from some of the past that we've had, and I mean, we're all in a very different situation than any of us have ever experienced before. So I think we're going to need all of our brains and all of our knowledge and collective wisdom to be able to move forward as a nursing profession, certainly in the acute care setting, but all of the health systems across the country, we need to be able to work together. And I think that's just such a huge thing, to know everybody's, I hope, and I believe most people are trying to do that, trying to better the care that's provided, to better the financial status of the organization. Everybody's trying to do the right thing and do it well by our patients and by our staff. So I think the more we can open ourselves up to that, despite our somewhat troubled history, the better off we'll be, and much faster.
Yeah. Well, thank you, Amy. This has been so great to chat with you and to learn more about how you've been able to build those collaborative relationships with the finance team. And hopefully it'll be more and more chief nurses will have those collaborative relationships, which directly impact staffing, which directly impacts, how recruitment and how great the work environment is for nurses. So I want to thank you for joining us today. All of us at Vivian Health say thank you. And to our listeners, if you have comments or questions or need more information, just please let us know. And you can reach us at hire.vivian.com. And thank you.